All right, thank you. I wanted to welcome all the residents and fellows who are joining us today for the Residents Forum at the 2021 AUA Conference. We're virtual again this year, but we have some great speakers from across the country here with us today to talk about fellowship in urology. I am Michael Ernst, the chair of the Residents and Fellows Committee for the AUA, as well as a current pediatric urology fellow at Nationwide Children's Hospital in Columbus, Ohio. And I'll introduce our panelists now. We're going to start with Dr. Derwish, who's a professor of urology at UC San Diego, a urologic oncologist. He was previously the program director at the University of Tennessee Health Sciences Center, as well as currently program director of urologic oncology at UC San Diego. Dr. Ricky, who is an associate professor in the Department of Urology at Yale, specializing in female urology and pelvic reconstruction. She's the program director for the FPMRS fellowship at Yale. Dr. Su, who is a professor and chair of urology at University of Florida, also a urologic oncologist, recently served as the chair of the fellowship committee for the Endourologic Society, and also of note was a finalist for AUA Residents and Fellows Committee Teaching Award this past year, 2021. Dr. Wessels, professor and chair of urology at University of Washington, a reconstructive urologist, and is the program director of their Trauma and Reconstruction Fellowship. And lastly, Dr. Giel, an associate professor of pediatric urology at University of Tennessee Health Sciences Center, Lebanon Children's Hospital, and is their program director of Pediatric Urology Fellowship. So the first question I'm going to ask would be, what are some unique aspects of applying to a fellowship in your field? And we'll start with Dr. Derwish.
Dr. Ernst, thank you for the honor and the opportunity of being on this panel. I think urologic oncology is one of these fields that has traditionally had a long-standing fellowship, but really encompasses a lot of the aspects of what many people would consider to be general urologic practice, such as nephrectomies or prostatectomies. So it tends to be a cornerstone of most academic departments and teaching facilities. So on one hand, you have ready access to potential mentors. On the other hand, it's a field that's in rapid evolution and development, where not only has the surgical paradigm shifted, but really in recent years, the advent of multimodality therapy and personalized medicine has really kind of weighed in heavily on the practice of the field. And that has created some dizzying and disorienting both situations as well as opportunities for potential trainees. And I think it's a field that's undergoing some rapid evolution right now, despite it really being a mainstay. And I think that as we move along, I think that you'll see as subspecialization continues that fellowships will continue to grow and expand and potentially add more trainees down the road, as well as more programs.
Thank you very much, Dr. Derwish. We'll move now to Dr. Ricky. Unique aspects of applying for an FPRMS fellowship.
So I think one of the things that's definitely unique about FPMRS, not just within urology, but within all training specialties, is that you can actually get to FPMRS either by urology or gynecology residency. And the fellowships tend to sit in gynecology or urology. Given that, and it's also one of the only two ACGME accredited urology fellowships along with pediatrics. So one thing I want to note is that to sit for the specialty boards, you have to go to an ACGME accredited fellowship, and a list of those fellowships is available on the SUFU website. The other thing is, again, because of the kind of dual nature of the training, just about all programs are required to have urology and gynecology, faculty from urology and gynecology backgrounds, but and many programs, whether they sit in urology or in gynecology, will accept trainees from either background. But again, you would have to check the information pages on the SUFU website or the AUGS website to get a little more information and just do your homework. That being said, the exposure to the two faculty backgrounds is different across fellowships. And so that's another thing to look into a little bit. Most institutions have just one fellowship with shared faculty. There are a few institutions that actually have two parallel fellowships, one in Gyn and one in Uro. And then there's a few like ours at Yale that is completely integrated. So there's just a significant heterogeneity across the fellowships. They are all overseen by ACGME. So there's a certain standard of training that I think you can be confident that you're going to get that level in. But within that, there can be, like any fellowship, like nuances to it. So I think talking to somebody in the field is helpful to understand that a little bit better. And trying to touch base with current or past trainees will also help applicants get an idea of some of the unique aspects of each individual fellowship.
Thank you very much. We'll move now to Dr. Sue, unique aspects of applying to an endourology fellowship.
Thank you, Dr. Ernst. I'm sorry, I was having a little bit of a Wi-Fi problem there, a technology issue. Let me just shut this off. Sorry about that. So the Endourology Society is probably one of the older societies. We were established in 1985, and we have a long history of being the innovators, I think, in the field of urology. And, we are a very dynamic society. I think the word I would use is diversity and flexibility in terms of our training programs. I think as a society, we are sort of, two parts: the endourology side of things, which is metabolic stone disease, a surgical treatment of stones, anything endoscopic. And then there's, of course, the ever-present laparoscopic robotic portion of our society. And so fellows or applicants that are applying for training have a huge range of programs that they can apply to. We have currently about 70 different programs, and this is an international society. And these programs really bridge two-year programs that are, more for perhaps those that are pursuing the arena of academics in their future. But there are also one-year advanced clinical training programs that are for residents that perhaps have not been exposed to certain areas of endourology or laparoscopy or robotics that want some fine-tuning in their skill set before proceeding to practice. And so, and also we have, fellowships that bridge both. So we have combined fellowships of 2 years as well as 1 year. So there's a wide spectrum of fellowship options that a applicant can seek. We are continuing to evolve, similar to many of the other fellowships, in terms of the diversity of what we're training. Within the Endo Society, we have the Focal Therapy Society that recently joined us under our umbrella. We have the Society of Urologic and Robotic Surgeons, SIRS, which is a big portion of our group, of course. And then we have the Engineering and Urology Society, which is, again, working with medical engineers, computer scientists to develop new technologies to further our field.
Thank you very much. We'll move on now to Dr. Wessels, unique aspects of applying for a GERS fellowship.
We might be the most unregulated of the fellowships, and there have been a few fellowships around for a long time, but a rapid proliferation in the last 5 years. It's sort of like the second generation from the founders who are now forming these fellowships. And so the GERS fellowship programs have traditionally been focused either on urethral reconstructive surgery or prosthetics, but recently there's been a lot of dynamic growth as well, just as in the other fields. And the areas that come to mind are robotic reconstruction of both the lower and upper urinary tract, gender affirming surgery, and many of the fellowships are now offering some training in that as they develop programs. Also transition urology between pediatric and adulthood. And finally, there's one other that I can't think of right now. There are 1 and 2 year fellowships. The last thing is the job landscape is quite complex as well, because there are a lot of people being trained. And so people who train in GURS tend to land in one of 3 areas: academic medical centers, integrated health systems, or large urology group practices. Because if you want to practice this subspecialty, you need to be in an environment where there are enough cases being referred to support a practice. So that's a brief overview.
Thank you, I appreciate it. And lastly, Dr. Giel, some unique aspects of the Pediatrics Fellowship.
Sure, thanks. So the thing that I think is really remarkable about pediatrics is it encompasses just about everything that my colleagues here have said about their individual specialties, but we get to do it all. And you know, we encounter endoscopic care of children, robotic surgery, minimally invasive surgery, reconstruction, oncology. It's all part of our practice. So it's perfect for somebody that likes a little bit of everything about urology. All the unique factors that we find in our field, we get to have in a setting where we're able to do those things. If you're someone who likes to specialize very specifically on one of those things, then certainly there is that opportunity within larger group practices at academic institutions. If you want to be somebody that focuses primarily on pediatric urologic oncology, that's absolutely possible. But if you'd like to do a little bit of all of these things, that's also quite possible. We're an accredited 2-year program. We were among the first specialties to have a subspecialty accreditation within urology, and so that's very unique. And then we also embrace research opportunities. And so there can be a wide variety. You don't have to be a bench researcher to go into pediatrics. There's a lot of different opportunities within the field to practice and learn to be a physician scientist as well. So I think it encompasses all the best parts of urology and allows us to take care of patients in a longitudinal fashion in a way that some of our colleagues may not always have the opportunity to do.
Thank you. Appreciate that. Our next question is going to be for Doctors Ricky, Gill, and Wessels. Pediatric urology, female urology, reconstructive urology often involve techniques, procedures, or pathology that some residents may not be exposed to at all during their residency. So what would you recommend to a resident who feels like they may be interested in that subspecialty, but doesn't have access to a fellowship trained faculty member at their home institution? We can start with you, Dr. Ricky.
Yeah, so I think that's a great question because there's been some resident research and I think also AUA collected data that just has shown that the exposure to female pelvic medicine can be sometimes one of the weaker links perhaps. And I don't know why that is. The demand is certainly there, but urologists are such a small group, and then specializing in one of our areas is even smaller. So I think that's changing. I think we have more and more people training. So I do think more and more departments are getting that exposure, but it can still be difficult. So one piece of advice I have is just to look within your institution. If you don't have somebody on the urology faculty, look at the gynecology faculty. There is often going to be someone fellowship trained. And even if there's a large, or not large, but a community group close to you, there may be somebody fellowship trained there. And I wouldn't get too hung up on whether they come from urology or gynecology. If you just want that exposure, you can look for it. And then it will, of course, take a little bit of coordination with your program director. But I find that, people in these institutions are educators and they really want to engage people in their field. And we work so closely with gynecology. Like I have residents from both sides. I train both residents. They both come to me for advice from within and without the institution. So it may take a little bit of detective work, but I don't think you're going to get much pushback, hopefully. The other thing is that SUFU has a really great resource. They have an annual FPMRS preceptorship that they call, and it was designed specifically for like recognizing this area for improvement in a lot of programs. It's a 2 or 3 day course in Chicago where you have faculty from all over the nation giving lectures, and it's an opportunity to network. And they had to, of course, put it on pause this past year, but the next one is in July. And it's on the SUFU website. It's July 29th through 31st in Chicago. It is traditionally held in January, but because of COVID and trying to make sure that it can happen in person, it was switched to July. So finally, there are some visiting resident rotations. I will say when you're looking for these in fellowships, I think in full transparency, these are a little rare and hard to find, but it never hurts to reach out to a program to ask if they have any rotation opportunities.
Thank you. That's excellent advice. And I think the SUFU training in Chicago and these away rotations. I know personal friends who have taken advantage of those. Really are excellent opportunities that I hope our residents now can know about. Dr. Wessels, what advice would you give to somebody who does not have a lot of exposure to reconstructive urology in their residency?
Well, there's always reconstruction going on. That's the thing. And it'll be our pediatric colleagues and our cancer colleagues and our FPMRS colleagues. So there is a lot of interaction that really follows some of the same principles. You'd have to go outside of the institution otherwise. And we don't have anything as organized as the other specialties, as you can imagine, but most program directors are very accommodating. If your program director of the residency will allow you to take a couple days, it's not a rotation, but you could come and visit. We set up observerships, or we have in the past, obviously not during COVID. And so that's one way. The GERS meeting at AUA is a great chance. And if you are able to go as a resident and go to that meeting before you have to apply, there's just a lot of people around. And lastly, the fellows and former fellows are a great resource. And at least in my program, they talk to dozens of people every year, and they're real advocates for the subspecialty and can provide a lot of information about all the fellowships, not just mine.
Thank you very much. And I'll also put a plug in. Our reconstructive urologists have been some of the best about putting out videos of the amazing work they're doing. And so you can kind of get a little bit of exposure, maybe not standing in the OR, but a lot of opportunities there. Lastly, Dr. Giel, personally, I'm in a pediatric fellowship right now. I graduated without ever having seen a Metrophenol or an augment. And so what would you recommend to a resident like me who is in residency and thinks they might want to do pediatrics?
Well, these days, most of our residents across the country do have some exposure. It might be varying as far as breadth and depth, but there is going to be some exposure. So I think mentorship is a huge component of training at all levels. And I think it's incredibly important to find a mentor. Most institutions will have some connection with pediatric urology just by the bearings of ACGME requirements for graduation. So there should be some access. And if for whatever reason a resident finds that she or he doesn't have access to a mentor, they're welcome to call me or any number of listed program directors. Each one of us on this panel today is doing what we do because we love the specialty, but we love training people to do what we do. And so I think everyone in academic training feels pretty passionate about being as much of a helper to those who are following in our footsteps as we can. So I think don't be afraid to pick up the phone or pick up your computer and send a quick email. I am confident that it would be met with a welcoming reception, as we would love to help take care of those around us who want to do what we do.
Thank you. Our next question will be for our urologic oncologists and Dr. Sue and Dr. Derwish. Oftentimes the robotic or minimally invasive surgery exposure in residency is really weighted towards the later years. Maybe this is changing currently. If a resident decides they may want to pursue an oncology fellowship or a minimally invasive fellowship later in their residency, maybe PGY 4 or 5, or even after the match, what advice or recommendations would you have for that resident? We can start with you, Dr. Sue.
Sure, thank you for that question. I do think that is changing. I think we recognize that training in some of these more advanced techniques, whether laparoscopic or robotic, are not so simple, and in fact takes some years of practice to learn a different way and of operating, because we're really no longer operating with our hands of the touch and feel that we have in open surgery, but really using our visual guidance. And so at our institution, we certainly have incorporated our junior residents into the rotations much earlier. I think that many other institutions around the country are doing the same. Simulation has been a very big part of training also to acclimate to a new environment. I think the key thing is, for our society, I think it's never too late. I mean, we have an excellent match rate, but there are programs that do go unmatched. And so there are programs that are looking for high quality people that may have decided late in their residency that they want to pursue minimally invasive training. So that's what I would say, is that, I think it is evolving. And I think that residents, hopefully are at programs that have that modern concept of integrating not just didactics, but early exposure in the operating room, simulation training, a lot of video-based training. We have a whole video library available on the NU Urology website. Also, the NU Urology website offers excellent webinars. We recently moved to a masterclass format of laparoscopy and robotic webinars, as well as NU Urology webinars that are available for those that may not have as much exposure at their residency to be able to watch, but also interact. And so I think the theme of what you're hearing is taking the initiative to reach out to people, to network, and not be afraid to do so, because as urologists, we're all very collegial and very supportive, as Dr. Gill just said.
Absolutely. And certainly my experience and many others, urologists are very approachable. And with current social media trends, it's easier than ever to reach out to really leaders in the field. It's things are open for people. And so I hope that the residents and fellows out there are taking advantage of that. Dr. Derwish, I'll open up this question to you as well, with a caveat that, you mentioned in urologic oncology, it's a rapidly developing, a lot of excellent science going on. To a resident who maybe identifies later in their residency, or maybe they're not associated with a large cancer center, what recommendations or advice would you have for that resident?
That's a great question. And I think it's to build up on what Dr. Sue and Dr. Gill were saying. I think the important thing here is mentorship and playing to your institutional strengths and adding to your intellectual toolbox from a relatively early standpoint. If there isn't necessarily a translational research that's urologic oncology driven, but there may be a fantastic mentor potentially available in medical oncology, then seek that mentor. Similarly, if there is more robust pediatrics or endourology research going on in your department, then seek those mentors and add to your intellectual toolbox. You'll find that the field is very, very well networked across subspecialties and disciplines. And oftentimes your mentors, even if they may be in a different subspecialty than urologic oncology, may know urologic oncologists who will be there to provide mentorship, whether they and support and advice as you apply. And I think the same thing kind of applies for another subspecialty that may not necessarily be represented right now, but is also part of the urologic armamentarium. Renal transplantation. Most departments do not have direct urologic involvement, or if they do, in terms of surgeons, may have them as part of a multidisciplinary transplant team. Seek out the mentors that are in your institution and play to those institutional strengths, and concentrate on the quality of your intellectual toolbox, and you'll find that that's going to take you a long ways.
Thank you very much. I think I'm going to have time for one more question that I'll direct to everyone, and that would be, when looking at an applicant's application, what do you value most? Is it their scores on in-service exams? Is it letters of recommendation, specifically comments on their clinical acumen, research output? So we can start with Dr. Gill. What's most or least valuable on a residence application?
Honestly, in an application, on actual paper, I find it very difficult to really get to the heart of who someone is. And to me, the most important part of the entire application process is the interview portion, because that's where we can really connect with someone and understand what their passions are and personalities are, because there's a lot of excellent training opportunities in both directions. And I think the most successful time that you have in fellowship is when you're a great fit with the people around you. There's personalities all over the place. If you're very, very interested in basic science research, then that fit needs to be there for you, and like-mindedness as well. And so to me, the most important portion of the entire application process would be the interview. As far as the application itself, the application materials, I think the letters of recommendation, because we are all very small subspecialties, you tend to know people at different institutions. So you really gain some insight that kind of opens the door a little bit to what you're going to be expecting to see in the interview.
Thank you very much. We'll go now to Dr. Ricky. On an application, what's most or least valuable for you?
And we're going to be, I feel like we just got done, and now I'm going to have to go through the whole screening process again. So I will say that, yeah, one of the things I do like to see is some effort put into the research process, and especially somebody, and it's not just because you're going to be, you know, a department chair somewhere at some point, but just to recognize that's important. I think it also shows somebody that's taken an idea from the beginning all the way through to IRB submission, data collection, and then manuscript preparation. It shows ability to manage a project, to up manage your mentor, to see something through to the end. So it just, I think it gives some insight into kind of the focus of that applicant. I personally do also like, and it doesn't need to be a ton of projects, honestly, and it doesn't have to be in your field if you change your mind at the end. But I think having sort of a meaningful research experience, even if it's one project, is nice to see. I do like the letters for the same reason that Dr. Gill says. It can give you a little bit of insight into some of the things that are difficult to assess on paper. Some of the qualities that we all find important, like being a good team player and being professional and different things that you can get in the interview, but in order to kind of take that first step to get to the interview. So those are the two things that I probably look at the most, honestly.
Thank you. We'll come now to Dr. Sue.
So hard to add to both of what Dana and Leslie's already said. So I'm going to say I'll echo most of that. The you know, I think the interview process is probably the most important, as Dana had said before. You know, I think ultimately underneath all this, we recognize in 1 to 2 years, we're looking for individuals that really have drive and passion, that really are going to capitalize on that moment in time. And so, you know, whether you get that through the interview or, you know, through conversations or letters from the people that are supporting them, I think that probably is the most important thing to me. Second is some investment in research, as Leslie had said, you know, and you know, Dr. Deweesh had mentioned this. It does not always have to be in that particular area. So I think the residents panic of that, you know, I have publications, but it's not in endourology. You know, it just makes us aware that there has been some investment in the field of urology and not just learning the clinical side, because that's the easy side. And as I said it before, we're really looking for people that are embracing innovation and new technology, right? People that really want to contribute to the field in a meaningful way and finding, you know, better ways of providing care to our patients.
Thank you very much. Dr. Wessels, within reconstructive urology, what are we most looking for on an application?
Well, this is where we're all giving our personal philosophy, and I've been doing this longer than everyone else, I think. And I've gotten more to a meta position where I'm looking for someone who can make an impact on our institution and then later go out into the world and make an impact. And so I'm actually recruiting for difference and for people who will add to the diversity of what we do. We learn a lot from our fellows, and we bring them in sometimes tactically for that reason. And then we want to send them out. And so I look at where I think they might end up. And are they going to go to an underserved area or an underserved population? And that's really where I've been trying to shift my focus, because I think everyone is so well trained and they will have the technical skills to be successful in all of our fellowships. I'm certain of that. And the people on this panel, they can train people to be really outstanding. So that's my philosophy.
Thank you very much. Appreciate it. Lastly, Dr. Derwish.
Yeah, I think that this is again, not to belabor the point, but I think to echo what this distinguished panel has said, I think the important thing is finding mentorship. I think in terms of us, what we look at from the actual applicants is a mixture of evidence of intellectual drive, passion, creativity. I think that we want to see in the letters evidence that they are technically highly competent, that they are organized, that they're team players, that they're professional and compassionate. I think those are the two main things. I think that the scores are there, but are really at this point secondary. I think that the number of publications and abstracts ultimately you have to normalize that within the respect to the circumstances that the institution that a resident is coming from. 3 publications from a place that's not academically driven may be far more impressive than 3 publications from a place that's a publication powerhouse, although you also have to factor in the impact of the actual publications and what the actual resident was doing. But I think finally, as what Dr. Giel said, it's really the ultimate element here is the point of contact in the interview and seeing whether you connect with the applicant or not. But to say one thing to the applicants, I would look at this process as really being a fantastic way to be able to start to network with potential future colleagues, as well as to see the differences in philosophies between these fellowship programs. Really, all of the fellowship programs within are outstanding. Each of them has certain specific strengths that attract different types of applicants. So it's really a mutual interchange of ideas, and we do look for at potentially what a fellow can bring in. Fellows bring in the traditions that they were trained with, as well as the philosophies, and they ultimately infuse a new vigor and blood into the program. And what they're going to bring in is as much as what we give them back as they go forward.
Thank you very much. I think a lot of residents out there are going to be reassured to hear what you say about publication specifically, and also all of the advice that you guys have been able to impart today. And I know personally, meeting the faculty in pediatric urology was one of the best aspects of the interview process. I think that's all the time we have for our panel on fellowships in urology today. I want to thank all of our panelists today for their time and insight. I hope the residents and fellows have found this to be interesting and helpful. The Residents and Fellows Committee is here to serve all the residents and fellows of the United States, as well as AUA training members across the world. So to the residents and fellows out there, I'd say that if there's ever a concern that you have that you'd like to bring to our attention, or an idea you have for future programming, please reach out to your section representative or to me personally. Our information is all available on the AUA website, and you can reach me via email or Twitter. So thank you to you all, and we'll now move on to our next panel, which will be moderated by Dr. Javier Desloges.